Hi class, this is Dr. Shahada, and in this video I'll be covering Chapter 11 titled Health Services for Special Populations. So in this week's module, you'll find the file for the PowerPoint presentation for the chapter, as well as a file for the terms that are covered in the chapter with their definitions. All right, so what I'm going to do now is, instead of going through this page, I'm going to switch over to the PowerPoint presentation for Chapter 11, and I'm going to address the topics found here on this page through the slides. All right, so give me a minute. Let me switch over. All right, so in this chapter, we are talking about underserved populations. So there are certain population groups that are at a greater risk of having poor physical, psychological, and social health. So some terms that are used to describe these groups include underserved, medically disadvantaged, underprivileged, and American underclasses. And here are some of the groups. So we have racial and ethnic minorities, uninsured children, women, rural area residents, homeless, mentally ill, chronically ill, disabled, and those with HIV and AIDS. All right, so now we're going to be touching on the topic of, or covering the topic of vulnerability. So vulnerability refers to the likelihood of experiencing poor health or illness. So the vulnerability framework that is actually presented in this chapter addresses this convergence between predisposing factors, enabling factors, and need characteristics at the individual and ecological levels. So what these factors or these characteristics determine, they determine one's access and ultimately influence one's risk of contracting illness or recovering from illness. Policy and interventions focus on the need to target these multiple risks. An example of this is the research that I usually work on. So I'm looking at HIV risk, risk of injection drug use, heroin use, with my research revolving around substance abuse. So the idea is to get, first of all, to assess the risks of them contracting HIV. What behaviors are they engaging in that put them at a higher risk? And the idea is for us as a scientific community to become more informed in order to create the policies and behavioral interventions, at least, in my area of research, to address the vulnerability or the risk that puts the populations or our sample at risk for, if it's the HIV risk or substance abuse, just to kind of give you an idea. So with this vulnerability framework, we're kind of looking at it in the same way. Here is the diagram. And again, this framework calls for attention to the convergence of vulnerability attributes. People who experience a combination of risk factors are likely more vulnerable and therefore ought to be prioritized by policy and intervention initiatives. The framework also suggests that public policy and programs must address several risk factors at the same time, rather than treating each risk factor separately and in isolation. So in the next slide here, the predisposing characteristics are listed. Some examples, which would include racial and ethnic characteristics, gender and age, and geographic location. Enabling characteristics include insurance status, homelessness, And need characteristics include mental health, chronic illness, and HIV/AIDS. So those are examples of each characteristic that we're looking at in relation to vulnerability. All right, so racial and ethnic minorities. So over 34% of the U.S. population is made up of minorities. We have about 12.2% Black or African American, about 15.4% Hispanic or Latino Americans, 4.4% Asian Americans, and about 0.8% American Indians and Alaska Natives. So there are significant differences that exist across the various racial and ethnic groups on health-related lifestyles and health status. Excuse me. So minorities are more likely to be economically disadvantaged than whites. They fall behind in health status despite progress made during the past few decades. Blacks in particular, compared to whites, have shorter life expectancies, higher age-adjusted death rates for leading causes of death. They also have higher age-adjusted maternal mortality rates and higher infant, neonatal, and postneonatal mortality rates. Blacks are more likely to report fair or poor health status than whites. In terms of behavioral risks, Black males are more likely to smoke cigarettes than white males, and Blacks have higher serum cholesterol levels than whites. All right, so in the next slide, this is actually, and there you see the web link, is a video on inequality, and it talks about this health disparity. So it's looking at how health is impacted due to your socioeconomic status. Now, the next couple of slides, the differences between racial ethnic minorities in relation to health will be listed. I'm not going to go through all of them. Actually, what I want to do is I want to jump to slide number 19, and I want to talk about the uninsured. All right, so about 11% of children are uninsured in 2009. 46 million are non-elderly, and the uninsured tend to be less educated, working in part-time jobs and or employed by small firms, and younger. So the age range usually runs between 25 and 30. Now, I do want to point out, after the implementation of the Affordable Care Act, the uninsured rate here in the U.S. significantly decreased. So it's about 11% in July of 2016 in comparison to where it has declined 6.1 percentage points since the fourth quarter of 2013. So there's been a significant reduction in the percentage of uninsured. All right, so here are a couple of facts regarding those that are uninsured. We have 1 in 10 uninsured persons that lack insurance by choice. In 2003, about 47% of uninsured people postponed seeking medical care due to the cost, in comparison of 15% of insured people. And I'm sure that doesn't surprise you. When you do have insurance, you know that healthcare is more accessible than it is when you know you have to pay the full fee at the time when the services is delivered. All right, so now I'm going to be jumping to slide number 23, and I'm going to cover children. All right, so in this slide and the following couple of slides, we are covering the topic of children as an underserved population. So the health concerns of children include lack of insurance, vaccinations, delayed access to medical care, and the unavailability of sick childcare, or lack of leave benefits for working parents. Now, there are a number of health services that are currently available to children. There's personal, medical, and preventative health services. So these services are generally delivered in private and public medical offices. So these personal, medical, and preventative health services also are delivered, as I said, in public medical offices, hospitals, and laboratories. There are also population-based community health services. These provide services such as immunization delivery and monitoring programs that lead to screening for children, as well as child abuse and neglect prevention. Now, there's also health-related support services. So examples of this would be health-related support services such as nutrition education, early intervention, rehabilitation, and family support programs. Services in this sector also include parent education, skill building in families with infants at risk for developmental delay due to physiological or social conditions, and education and psychotherapy for children with HIV. So those are some of the health services that are currently available to children. The following slides, again, are just touching on a number of different topics in relation to children. And since I am jumping around, the next topic that I would like to cover is women. So I am going to slide number 29 and just touch on the topic of women a little bit. All right, so here is another video. As you can see, there's the link. Just press Control while clicking on the hyperlink, and you should be directed to YouTube to watch the video. And it talks about gender differences, so in relation to health outcomes. So let's look at women here. So the leading providers of care in the nursing profession are women. Also in the areas of allopathic and osteopathic medicine, dentistry, podiatry, and optometry, women in the U.S. live 8 years longer than men, but they suffer greater morbidity and have poorer health outcomes. Health problems restrict women's activities by about 25% more days each year than their male counterparts, even when reproductive conditions are statistically controlled. So women suffer greater morbidity and poorer health outcomes and have a higher prevalence of certain health problems than men over the course of their lifetimes. Women also develop more acute and chronic illnesses, resulting in a greater number of short and long-term disabilities than do men of a comparable age. Women are bedridden 35% more days than men each year due to infections or parasitic diseases, respiratory diseases, digestive system conditions, injuries, and other acute conditions. In all illnesses, differences arise not only in the onset and progression of illnesses, but also in the research, prevention, treatment, and education necessary to address these physical and mental disorders in women of all ages and across all racial and ethnic groups. So the next couple of slides just address the health differences. And here are Substance Abuse and Mental Health Services Administration are targeting 6 areas for attention. And specifically with women, we're looking at physical and sexual abuse, women as caregivers, women with mental and addictive disorders, women with HIV AIDS, STDs or TB in relation to women, older women, and women detained in the criminal justice system. Women are principal users of the healthcare system, both for themselves and as the family care coordinator. So until the age groups of 65 and older, women have higher physician utilization rates than men. However, hospitalization rates are comparable for men and women. So there really isn't a significant difference there. Women work more part-time jobs than men, receive lower wages, and with more interruptions in their work histories. Women are at a higher risk to be uninsured and are more likely to be covered as dependents under their husband's plans. Women are twice as likely to be covered under Medicaid because the program is linked to aid to families with dependent children, also known as AFDC. Now, this slide talks about the Office on Women's Health. The Public Health Services Office on Women's Health is dedicated to the achievement of a series of specific goals that span the spectrum of disease and disability. These goals range across the life cycle and address cultural and ethnic differences among women. The OWH stimulates, coordinates, and implements a comprehensive women's health agenda on research, service delivery, and education across the agencies of the Public Health Service, including NIH, CDC, or let me say these out, National Institute of Health. CDC is the Centers for Disease Control and Prevention, FDA, or Food and Drug Administration, the Health Resources and Services Administration, which is HRSA, and the Agency for Health Research and Quality, AHRQ. So there's also the Substance Abuse and Mental Health Services Administration and the Indian Health Service. So the OWH also serves as a link across the country's public health system regions and with other government agencies. So as you can see, the role of the OWH, they're involved in a number of different aspects in relation to aspects of women's health. All right, so rural health. Rural health, there's poor access. People living in rural areas usually have poor access due to poverty, long distances, topography, weather, and availability of health care and transportation. So these challenges listed here, there's a lack of healthcare professionals in rural settings. About 20% of the U.S. population resides in areas where primary care health professionals are in short supply. And there's usually a low population density that's in rural areas, which makes it difficult for communities to attract physicians and managed care. So this leads to rural population facing greater barriers in accessing health care than urban populations. So the scarcity of healthcare providers encompasses a broad spectrum of professionals like pediatricians, obstetricians, dentists, nurses, internists, and allied health professionals. All right, so as we've discussed earlier in earlier chapters with the shortage of primary care physicians, specifically in rural areas, they always, there's been strategies in place trying to get primary care professionals, if it's a primary care physician, a physician's assistant, or a nurse practitioner, out to rural areas, either as a mobile clinic or, to run a clinic. And then what's been very helpful is the use of the internet so that healthcare or the care of a patient can be coordinated. So the primary care physician needs to consult a specialist, they are able to, even though there's a long distance between them, which is, we addressed in medical technology, the topic of telehealth, which is really a great tool, especially with the issues regarding access to healthcare in rural areas. And there's also been a number of various measures that have been taken to improve access to care in rural America. And this includes the promotion of the National Health Service Corps, the designation of health professional shortage areas, which are also known as HPSAs. It is covered in more detail in your textbook, and medically underserved areas, or MUAs. Also, the development of the Community and Migrant Health Centers, and the enactment of the Rural Health Clinics Act. So these are kind of the measures that have been taken to improve access to health care in rural areas. So here's a video on rural health care. There's also a couple of videos in this week's module that address rural health care, specifically migrant farm workers, just because that's been an underserved population that I've been very interested in and done quite a bit of research on. And I'm trying to think what other videos are included, and also a topic of mobile clinics. So there's a couple of videos that I'm sure you'll find interesting. All right, so I mentioned a couple of measures that have been taken to kind of address this issue with access to healthcare, and one of them was the National Health Service Corps. Now, it was created in 1970. The idea is to recruit and retain physicians in shortage areas. A scholarship and loan repayment program, very smart. So this is kind of like an attractive offer to try to get physicians in areas where there is a shortage. Another measure that's been taken that I very briefly just listed is the Health Professional Shortage Areas, HPSA. So the Health Professions Educational Assistance Act of 1976 provided for these HPSAs, which is really a federal designation indicating an area has shortages of primary medical care, dental, or mental health providers. So HPSAs may be urban or rural areas, population groups, or medical or other public facilities. Then MUAs, which is really the Index of Medical Underservice, has been developed to target the community health center and rural health clinic programs. And then we have community and migrant health centers. So here's another video talking about migrant workers, medically underserved. And what community and migrant health centers, they provide services to low-income populations by establishing sliding fee scales based on income. Minorities are the highest users of their services. And believe it or not, in Immokalee, when we were running an HIV risk reduction project, intervention project up there, we started with their migrant health center to try to recruit migrant farm workers before actually going out to the fields and trying to recruit participants. All right. So here it says, they service low-income populations on a sliding fee scale, serve about 18 million patients per year. 22% are Black, 34% are Hispanic, and 4% of other minorities. All right, so now I'm actually going to jump to the topic of the homeless. So the estimated amount of people that are homeless are about 3.5 million. But you do need to keep in mind that the exact number of homeless in a given year is unknown. About 19% of those people live in rural areas. Now, the economic picture of the homeless person people is dismal. Almost half have not graduated from high school. And on average, they have been unemployed for 4 years. Only 26% have health insurance. The shortage of adequate low-income housing is the major factor for homelessness. Unemployment, personal or family life crises, increases in rent out of proportion to inflation, and reduction in public benefits can also directly result in the loss of a home. So the homeless, both adults and children, have a very high prevalence of untreated acute and chronic medical, mental health, and substance abuse problems. So the state of being homeless produces risk factors that would other ways not be incurred, including excessive use of alcohol, illegal drugs and cigarettes, sleeping in an upright position, extensive walking in poorly fitted shoes, and grossly inadequate nutrition. I do want to also point out that the homeless population is definitely at greater risk of assault and victimization. And the homeless are also exposed to illness due to overcrowding found in shelters and overexposure to extreme heat and cold. All right, so now I am going to start covering the topic of mental health. All right, so about 25% of Americans have a mental disorder in any given year. And it has been found to be higher among women and individuals between the ages of 18 and 25. The burden on health and productivity is only second to heart disease. And many people with mental illnesses tend to go untreated. Mental illness is a risk factor for suicide, cardiovascular disease, and cancer. Now, the most common mental disorders are phobias, substance abuse, alcohol and drug dependence, and affective disorder. Depression is the most common illness among primary care patients, and it affects approximately 14.8 million adults in the U.S. And I would like you to make sure that you read the section on mental health in your textbook and go through the rest of the slides. I am going to cover the topic of HIV and AIDS. The chronically ill and disabled, and then HIV and AIDS, and that should wrap it up for this video covering chapter 11. All right, so this slide starts the section in this PowerPoint presentation addressing the topic of the chronically ill and disabled. So this demographic presents challenges to our health system that is oriented toward acute care, because the U.S. healthcare system is primarily focused on acute illnesses. A significant number of deaths, almost 50%, are attributable to preventable chronic conditions. Health promotion and disease prevention programs can play a significant role in the prevention of chronic illness. As chronic disease and disability continue to increase due to an aging population, the healthcare delivery system needs to be refocused. Now I'm going to jump to the slide touching on HIV AIDS. So HIV is the human immunodeficiency virus. The virus comprises the body's ability to handle disease and causes AIDS. And it literally is, a deficiency with the immune system. Okay. So HIV can be transmitted through the contact with infected blood, semen, or vaginal fluids. So that means it can be spread by sexual contact, injection drug use. If you're sharing needles, that's another way. Obviously, you cannot contract HIV by touching someone's hand that's HIV positive, or saliva, or it literally needs to be the transmission of infected blood, semen, or vaginal fluids. Now, within a few weeks of someone having HIV, there's that 6-month window of where you might have it, and it may be so early on that it isn't detected if you test for it. And what happens usually is you'll have flu-like symptoms, usually fever, sore throat, fatigue, can occur. Then the disease is usually asymptomatic. Now, it essentially progresses into AIDS, acquired immune deficiency syndrome. However, now with the antiretroviral regimes that are available, or the medication, it dramatically slows the progression of the disease. So you actually can stay in the stage of HIV, and this is where HIV turns into this chronic disease. Now, a little about AIDS. So it is related to HIV again, but they are not one and the same. A person has AIDS only in the final stages of HIV. After the immune system becomes unable to defend itself against foreign invaders like bacteria, other viruses, and allows the development of certain cancers. Now, there is a great movie titled "And the Band Played On," and it talks about the discovery of the HIV here in the U.S. And it was actually coined as HIV in 1981. And it's like this team of epidemiologists. They're actually a mix of like an epidemiologist, a physician from the Centers of Disease Control and Prevention, and how this team goes out and they start mapping out how this virus is spreading in order to better understand how it's being contracted, how severe it is, and who is being affected. But it really is a great movie, very well made, and just very interesting because it takes you right from the beginning of when HIV, the first cases were emerging and they didn't understand what this was yet, So that's a great movie to watch. All right, so let's see here. So there are a couple of things I wanted to touch on. First, in 1994, the death rate for the HIV infection per 100,000 people among the ages of 25 to 44 was almost 4 times as high for Black men as for white men, and 9 times as high for Black women as for white women. Now, in 2004, males and Blacks continue to have significantly higher prevalence of AIDS than females and whites. Now, those increasingly affected by this disease are the poor and disenfranchised in society. So there's a growing recognition of the spread of HIV into rural communities. Rural persons with HIV and AIDS are more likely to be young, non-white, and female, and more likely to have acquired the infection through heterosexual behaviors. Women are a rapidly growing proportion of the population with AIDS and HIV. So while the majority of people with AIDS are men, the number of women progressing to AIDS is increasing almost 4 times as fast as the number of men. Black and Latino women are particularly vulnerable. All right, so now I'm going to jump back to this week's module and make sure that we've covered everything that is there. All right, so we have the vulnerability framework, talking about the different underserved populations that were covered in this chapter. I don't want to make you a bit dizzy. I just want to make sure. Perfect. Okay, so make sure to read my notes that I have on this information from the chapter section in this week's module. If you have any questions, be sure to let me know. Make sure to read the chapter and go through all the PowerPoint slides. If you have any questions, do not hesitate to let me know. Take care.